Okay, welcome back. Our next session is Addressing Health Equity through the Oral Health Progress and Equity Network. Here to speak today are Stacey Chazin and Kristie King. And I think, Stacey, I still try to make your last name Cajun.
That's okay.
Stacey holds a master's degree in public health from Temple University, a bachelor's degree in communication from the University of Pennsylvania's Annenberg School for Communication, and a bachelor's degree in economics and marketing from the University of Pennsylvania's Wharton School. She is currently pursuing a master's degree in organizational development and leadership at the Philadelphia College of Osteopathic Medicine. Stacey is a busy lady. She also leads capacity building, training, and technical assistance from the Oral Health Progress and Equity Network, or OPEN, which is made up of more than 2,000 advocates, organizers, providers, policymakers, and other oral health stakeholders across the country. Prior to joining OPEN, she spent nearly a decade with the Center for Healthcare Strategies, a national health policy center, where she was director of prevention programs. Christy King is a social worker and community advocate with nearly 20 years experience in nephrology, which includes providing direct clinical services as a nephrology social worker and developing various community-based initiatives. She earned a Bachelor of Science degree in psychology from Wayne State University, along with a Master of Social Work. Her leadership experience has included both the nonprofit and government sectors, strategically focused on building community-based health and well-being, often with special attention to the aging population and issues of equity. Currently, she is the Association Executive for the Southeast Michigan Senior Regional Collaborative, a nonprofit association of government and nonprofit organizations that serve seniors and persons living with disabilities. Kristie is committed to community empowerment and overall systems change. Her passion for community engagement lends her expertise as a social justice facilitator, complementing her dedication towards achieving equity through diversity and inclusion practices. Welcome, Stacey and Kristie. Thank you for being here today.
Thank you so much. And thank you to Melissa and Meishan for the invitation to join you here today. I am so lucky to be working with an organization that has volunteers and leaders such as my presentation partner, Christy King, and Dr. Cawthorn, who we just heard from. We are blessed and lucky and grateful for the time and passion and commitment that they all bring. And Dr. Cawthorn is a tough act to follow. We're going to do our best. I always learned so much from her and felt a little validated hearing her make a number of the points that we're going to be making as well through a slightly different lens. So I think we're a well-oiled machine here at Open with our leaders. So our objectives for today are that you all will come away from this presentation with an understanding of the evolution of the Oral Health Progress and Equity Network, or OPEN as we call it, and how its focus on health equity and anti-racist work have evolved over the past decade. Connections between structural racism and social determinants of health that are related to the oral health and overall health of individuals and communities. Current open efforts to address structural racism and equity, and ways that you all can become involved in the network. And before we keep going, actually, I am going to ask, we have a couple of places in the presentation where we're going to pause for questions, but please feel free to use the Q&A function as you did in Dr. Cawthorn's presentation to share any questions that you have, sending them to panelists and all participants. Also feel free to use the chat function if there are any perspectives that you'd like to share with all of us. So we actually want to start off by doing a quick poll just to get a sense of your foundational starting point today. And are going to ask our IT gurus here to launch a poll. And to answer this, how would you describe your current understanding of oral health as an equity issue. I would actually hope that it's a whole lot stronger than when you woke up this morning based on Dr. Cawthorn's presentation. But our hope is that we'll help to move it along even further. So how would you describe your current understanding of oral health as an equity issue? None, a little, I think I get it, or I'm a pro? And Joseph, will you tell us when we have a critical mass of responses?
Yep.
Okay, I think I get it. So I'm gonna attribute some of that to Dr. Cawthorn's excellent presentation, and also hope that and expect that folks came to the summit today with some foundational understanding. So 75% say, I think I get it, and wow, almost 20% are saying I'm a pro. That's great to see. So I'm going to start off talking about Open and give you a little background on who we are. So Open is a national network that works toward a vision that communities thrive because oral health is valued as essential to well-being, and that equitable opportunities ensure that everyone realizes their full potential. We now have more than 2,500 individual members of Open who come from a really wide range of local, state, and national organizations, some that are working primarily or exclusively on oral health, and others that work in a related or tangential area. They work on issues related to primary care, disability advocacy, education, academia, equity, philanthropy, et cetera. And these members come together virtually and in non-pandemic years, in person as well, in various places around the country, to work on issues related to oral health, overall health, and equity, contributing to improved oral health across the lifespan, particularly for low income and other vulnerable populations. The driving force behind Open is a collective commitment to take on America's oral health challenges so that everyone has an equitable chance to thrive. And here we're recognizing the direct connection between oral health, overall health, the right to live a pain-free life, to be employed, to prosper, and to feel secure. So I'm going to share a brief overview of how Open came to be. Looking back to the start of the century when organizations were really working individually to improve oral health policy programs and care delivery, work was mostly fragmented with little coordination or connection, and there was little national level activity that was happening on a unified basis. In 2011, the DentaQuest Foundation, which then was the philanthropic arm of DentaQuest, a national dental benefits provider, catalyzed a new national network through regional, national, and issue-focused convenings. So they focused, for example, on 4 different regions of the country who were working to improve oral health. They looked at issues related to Medicaid, to Medicare. They created an online workspace for their grantees and created other learning and collaborative opportunities for organizations that were receiving funding from the foundation. At the time, DentaQuest took a monumental step of issuing state-level grants to 25 states to build their collaborative capacity to improve oral health, and created opportunities for these states to come together, again, virtually or in person, to do shared learning. These 25 states ultimately became the bedrock of our network. In 2014, the 25 states and other national organizations that were working to improve oral health created a network that was called Oral Health 2020, which was the precursor to Open. And 2020 referred to the year by which the network was going to achieve a wide range of goals and targets. In 2016, the network expanded and created an infrastructure with leaders who came from grantee organizations and other members of the network to begin driving forward the work of the group, defining specific targets, specific goals that weren't dictated by the foundation, but that arose out of the membership's own priorities and organizational missions. In 2018, Oral Health 2020 was relaunched as Open, which we are today. And in 2020 and beyond, we're now seeing the DentaQuest Foundation, which is now known as the DentaQuest Partnership for Oral Health Advancement, is refocusing its philanthropic giving. And we have a new backbone organization that is called Open Inc., which is providing technical assistance to network members, working to deepen connections and collaborative learning, and figure out a way for the network to be financially sustainable into the future. As members of Open work together, we're driven by a number of principles, beliefs, and values that I'm going to talk about here. So first, we know factually that there's a direct connection between oral health and both physical and mental health. Poor oral health raises one's risk for cardiovascular disease, for stroke, for complications in pregnancy and childbirth, and other adverse health events. Individuals who have visible signs of oral disease, such as missing or deteriorated teeth, also face social judgment and stigma. This can be particularly harmful to kids who might be teased by their peers and have low self-esteem as a result. And it can also affect social interaction among adults. Some of the facts I'm going to share here, we also heard from Dr. Cawthron. In a survey by the ADA's Health Policy Institute, which she also cited, about a third of low-income adults have reported that the appearance of their mouth and teeth has adversely affected their ability to interview for a job. So this can translate to lost earning potential and continued lack of access to dental benefits, which otherwise might be provided by an employer. This impact is especially felt in states that do not have an extensive Medicaid adult dental benefit, where individuals don't have other options for payment to be able to afford regular dental care, and ultimately increased healthcare costs that are borne by society. A helpful metaphor that we use when describing disparities in this space is that accessing good oral health is like going through a series of locked doors. Examples of locked doors could be social determinants of health, such as living in a food desert, living in a community without fluoridated water, lacking comprehensive dental insurance, not having access to transportation to get to a dental appointment, or living in an area with very few providers who will see you, who will accept your insurance. These locked doors, unfortunately and not surprisingly, appear along the typical lines of disparities, such as race, ethnicity, income level, and place, and can prevent access to critical things such as fluoridated water and nutritious food, insurance that covers dental care, and providers who accept different kinds of health insurance. Unfortunately, while some people have all the keys they need to unlock these doors, many do not, driven largely by the all too frequent culprits of place, race, and socioeconomic status. So in Open, we believe that to build a healthier nation, we need to make sure all people have the keys they need to access good oral health. And this is what a just oral health system looks like. So in Open, we talk about oral health as a targeted justice issue. When we rebranded our network in 2018, we included equity specifically in our name because we know that everyone should have the same opportunities to live a healthy life, of which oral health is a critical part. And because oral health is vital to overall health, which I know we're all aware, Open advocates for and mobilizes those who don't have the keys needed to access good oral health care and prevention. And I'm thinking back to some conversation that went on in the chat during Dr. Cawthron's presentation about the disabilities community having a saying, nothing about us without us. And that's something that we have really strived to keep top of mind in open. I know that I personally have had a journey in that space, and really moving beyond what I learned in my public health program, where that wasn't talked about so much. And I needed to be part of this work and interact with people in the communities that we're trying to serve, and people who are leaders and volunteers in open who live in those communities and work directly in the communities, to have my eyes opened about that. And it's something that we really strive to drive home in the work that we do, and not just to say it, but to live it. So to focus on oral health as an issue of equity, the network launched a health equity work group in 2016 to make sure that all of our work was being planned and implemented through a health equity lens. And as Dr. Cothran mentioned, there are many definitions out there about health equity. The work group took one definition that was put in the space by Dr. Kamara Jones and adapted that to come up with what we have on the screen. So attainment of the highest level of health for all people. Achieving health equity requires valuing everyone equally, focusing on societal efforts to address avoidable inequalities, recognizing and rectifying historical injustices, addressing contemporary injustices, eliminating health and healthcare disparities, and assuring structural and personal conditions are in place to support optimal health. So despite major improvements in oral health for the population as a whole, oral health disparities exist for many racial and ethnic groups, again, by socioeconomic status, gender, age, and geographic location. When we look at race and ethnicity, for example, individuals who are Hispanic, non-Hispanic Black, or non-Hispanic Asian generally have the poorest oral health of any racial and ethnic group in the United States, illustrated here based on the percent who have dental caries. We also see that non-Hispanic Blacks, followed by Hispanics, have the highest rate of untreated dental caries. Income and education, not surprisingly, are also associated with untreated tooth decay in adults. We see here that low-income, non-elderly adults have rates of untreated tooth decay that are 2.5 times that of higher income individuals, and that those without a high school, those with less than a high school education rather, have rates also that are 2.5 times that of those who have graduated from high school. These disparities, unfortunately, were highlighted in the past year's tale of two pandemics, as we unfortunately call it, the COVID-19 pandemic and the pandemic of structural racism. The two pandemics intersected in 2020 and combined with foundational disparities in both health and healthcare, leading to a disproportionate impact of COVID-19 on people of color. We know, for example, that there is less access to quality healthcare in many Black communities, and Black people are more likely to suffer from diabetes, from hypertension, and from other underlying conditions that elevate the risk of death from COVID-19. Existing healthcare biases among providers were also highlighted this year, unfortunately. For example, it was found that people of color were turned away from hospitals more frequently, and their symptoms were not taken as seriously. Research found that Black people who visited hospitals with COVID-19 symptoms early in the pandemic were less likely to get tested or to be treated than white patients. Accordingly, and I'll provide some data that's even more current than what we have here on this slide, compared to white people, the risk of hospitalization due to COVID-19 is 3.7 times higher for American Indians and Alaska Natives, at 3.2 times higher for Latino individuals, and 2.9 times higher for Black non-Hispanic individuals. Similarly, when we compare data to white individuals, the risk of death due to COVID-19 is almost 2.5 times higher among American Indians, Alaska Natives, and Latino persons, and almost 2 times higher among Black non-Hispanic individuals. As members of OPEN considered all of what I just described over the past several years, the network's approach to addressing equity evolved. And I say this speaking both to the mindsets that members had coming into our meetings and our forums, as well as the way we designed our discussions and meeting sessions. Initially, we were very focused, and we saw a lot of focus on individuals. So individual behaviors that might be driving disparities and what the disparate outcomes look like. And then over time, our conversations evolved to start looking at underlying disparities, inequities, and structural racism that might be responsible for those outcomes. And I'm guessing it won't surprise you that we saw some pushback to that from many people. I myself, as a white person of privilege who had not had much exposure to these types of conversations, I needed to undergo a mind shift that that needed to be facilitated and was facilitated by my involvement in Open. And we saw that over several years of shifting the conversation in that way, that members of our network were able to more willingly, I don't want to say comfortably, because we've encouraged them to be uncomfortable in these conversations, but there's been more of a willingness to participate in uncomfortable dialogue and to really confront the underlying issues that are driving the ultimate disparities in health outcomes that we're seeing. Another thing we did, which Kristie's going to talk about as well, is we began to look internally to see what power structures and dynamics might be present within our network that were leading to our own inequities. So we looked internally at the same time that we continued to do our critical work to affect change out in the world. So I'm going to take a breath here and see if there are any questions that folks want to pose in the Q&A box. I'm not seeing any yet.
I'll need to share my screen.
Yep. Okay, I'm going to stop my share.
There was some comments in the chat, I know.
Oh, I see. Okay. Thank you. Yep, the buy-in has to come from oral health practitioners.
Are you guys seeing my screen or my notes?
We can see your screen.
Not my notes.
Not your notes.
It's a great thing then. Are there any other comments? Anything else, Stacey?
No. Actually, I'm just going to finish reading that. I lost the chat screen for a moment. Okay, so we have a comment. The buy-in has to come from oral health practitioners who are usually conservative white males. They don't live in these neighborhoods and are far removed from the impact of underserved communities. But when presented with the challenges, most are willing to assist with barriers that prohibit equity to access, for sure. And there's a question, I understand sharing the statistics, but are there reasons why these numbers are higher for African Americans than other non-African American populations? Kristie, do you want to speak to that?
And what's the question? Because I'm like in another screen. What's the question?
So there's a question. I assume that the statistics that we shared about the higher rates of hospitalization and deaths. So the question is, why are the numbers higher among African Americans than other? I assume when you say non-African American, meaning non-white, but other people of color. I'm going to assume that's what that means.
And I invite other people to add into this, but I think from my experience and my thought process is that when we're looking at communities, when we're looking at African American communities and we're looking at the higher numbers, we're looking at those disparities that are often found in society, period. Those disparities are higher because just the numbers across the board are higher. Urban areas sometimes typically may be with African Americans. So I apologize, I did not read the question directly. So I'm hoping I'm kind of getting to the answer. But I think it's when we look at communities, we have to be holistic and think about what communities we're talking about. We have to think about the access to the resources that are in and around those communities as a whole as well. Regardless if it's an African-American community or if it's another community of color that may be impacted as well, and how that actually plays in on their ability to have access to oral health services or have access to other and when I'm saying access, I'm not just necessarily talking about the physical access of going to a doctor, but really the other resources that play into creating the disparities that we see in our health challenges. And I see that the chat is blowing up here. And I'm gonna get started if that's okay, Stacey.
Yeah, I'll keep an eye on the chat. Go ahead.
Okay, so just to kind of move us forward and to talk a little bit more, and I think to give us an idea of where Open is going from where we've been, we are continuing. I love this slide because it really looks at and talks about our journey. It really looks at and talks about kind of where we've been and where we're going. And I'm just gonna go, yes, and where we're going. So, you know, Stacey has talked about the Open Network, and she's talked about how we've had tremendous growth and transitioning over the years, how we've assisted in providing access to all of those doors and those keys through all of our connections, and throughout the network, weaving this throughout the network, connecting folks, engaging people, having those conversations, developing our language around equity, concepts of equity, as she noted, our examples from Disparities and having those conversations to conversations around inequities and what that feels like, and structural racism, systemic racism, having those conversations and what they feel like for our members. Having other conversations around anti-racist work. What does that mean? Talking about privilege, and Stacey talked about her privilege and bringing that into the room and bringing that in, and how working through Open really helped her through her own journey. No matter what our transitions have been, we have always stayed focused on the importance of establishing oral health as health with an equity lens, and how achieving oral health, I'm having a time with these notes today. And how achieving oral health success is truly a social justice issue. That's always at the forefront of our conversations. So our journey for health equity now, what it looks like, we've been very deliberate. Open's transition is really just a bigger journey, a journey that's going to continue. As we continue on to this journey, we continue to reimagine how to best build and ground the network in equity, holistically, internally, externally, and organizationally. So not just looking, you know, Stacey mentioned the focus before with the health equity work group on individual, but moving that out and feeling how do we help the individual and empower an individual and move that out as well into the organizations in which they serve, and making sure that we continue to build the individual as a whole. So grounding for overall impact. Our impact within the network that moves us professionally and personally into the environments that we interact. As we reimagine and look at the impact of our work, we also seek to integrate our messages with a purpose, integrate our lessons of oral health equity and the achievements experienced across the many organizations and individuals that interact with Open. Integrating these lessons also come with transparency, and we've learned that sometimes the hard way. In these lessons that we have learned, we've been taught through our collective as well as our individual experiences and our knowledge gains. There have been many lessons along the way, good, bad, and the ugly sometimes, and we'll talk a little bit about this in the network. But overall, it's really lent itself to accountability to and within the network, externally as we address social justice issues across the spectrum, because we know it's much bigger than just oral health, and how this all ties into oral health. As leaders, we recognize that we have to remain and be authentic messengers and representatives of the network, professionally and personally, developing ourselves to serve in spaces that may be of discomfort. That in this work, we may be challenged to investigate the lenses in which we function, which sometimes causes us to look at ourselves, how we are practicing this accountability to ourselves and accountability to communities that we're touching. Is it that you're just talking about equity when you're in these spaces, in your workspaces, or are you bringing that lens outside into your everyday living as well? And so I know everyone is seen this slide in some form or another, really how we grounded the network. Network is rooted, our whole conversation, that difference between equity and equality and giving people what they need when they need it. We've been no different here, and we continue to use that as a grounding around equity in the network. We remain rooted, as noted, and always consider how to give people what they need versus equally providing everyone with the same thing. Although sometimes it appeared that we gave everyone the same thing when we talked about our messages of systemic racism and disparities and inequities. In our grounding, we recognize that we created and we're creating spaces where people came together with varying perceptions on equity, on equality, and what other associated words meant. Our goal is always to bring everyone along and assist them with developing an equity lens to oral health and health, and one that extends, of course, beyond oral health, but that flows into everyday interactions. I think for me, along my journey as well, I came into this network not as an oral health provider. I do not do oral health services on a day-to-day basis in no aspect of my work, but I was an advocate of social justice. I've been doing a lot of organizing, coalition building here in the Detroit area. And so the concepts that were presented were very easy for me. I understood them. They felt like this was going to be a safe space for me. And I traveled along that journey coming into the network probably around 2015 or 2016. So I was in the Oral Health 2020, we're going to make it happen. But I was also able to see how this oral health work connected to my work in older adults and working with seniors. So understanding the impact of oral health on our older adult population and bringing that lens back to my work. So once again, figuring out how I use what I'm learning, not just around disparities and inequities, but also how I take that oral health message back into the communities in which I was touching and serving on a daily basis. Sometimes along that journey, though, there were a lot of experiences. There was a lot of lessons learned. Sometime coming to that table, I was unsure of the conversations that were being had. I was a little puzzled, confused. I was definitely baffled sometime and just lost. And I say that because not that it was something wrong, but just sometimes our messaging didn't always come across when we started talking about and having those conversations around equity. And Stacey mentioned how there was this individual focus around behavior change in the beginning. And I was in those stages in the beginning of the behavior change and having those conversations. And this journey of equity is, everyone is on their own path. And we're still working on it because we're on our own path. As a grassroots network member, I remain dedicated, true to the community, boots on the ground, as we would say, work to move our ideas forward. Not just ideas about oral health, but those ideas about how do we tackle inequities that we find within our communities. I often think of Open as this big social experiment, where you have all of these organizations from across the country and all of these people that come from different walks of life, different geographic spaces and experiences, different lenses that were very, you put them all in one room and then you give them a message and then we try to talk about it. The intent was always good. Sometimes the impact didn't follow that intent that was there. That's our transparency. Sometimes materials were triggering, and we know these discussions are very sensitive to many, but materials were sometimes triggering. Discussions sometimes were not thorough. Sometimes there was too much that was just left in the air. There was no resolution sometime in our discussions. There was no time for us just to sit in the space of these messages. There was little dialogue to help us process through and even navigate or negotiate that behavior change that Stacey talked about. Considerations of where our oral health audience came from continue to be very important. And as Stacey mentioned, continue on this journey on how we change the design of the work that we do and how we engage and interact with our open network members. We want to make sure that we're understanding and that we're being relatable, and that the audience can relate wherever and whatever space that they're in, and they feel that this is a safe space for them to have these conversations. And maybe they don't want to have the conversation, but they want to just come to this space and learn. We want to make sure that our members are feeling empowered through our interactions. This is a huge, huge experience for many. And sometimes it was, as Stacey mentioned, the first time you come into a space to talk about some things that maybe you thought you heard about it on TV, but now you're really talking to people that's experiencing this and working in communities to make things different. So alone we were smart, but together we were brilliant, and we realized that, you know, we didn't always get it right, as I mentioned, but we continue to have several concerned voices at the table to ensure that we provided a constant, good, solid education and tools across the network. Education around health equity, what equity is, equitable practices, discussions that lended themselves to talks about systemic racism, oral health as health. For me, that was more of a newer concept. The impact of the social determinants of health and how we all play a role. We want to reinforce health equity as a shared commitment of open. We seek together to continue to build understanding throughout open around what health equity looks like across the different levels of work and how it can be further integrated into our work and the work of our network members. We together wanted to make sure that we're able to encrypt and integrate and equip all of our network members to be agents for health equity by integrating the concepts of health equity into their work. So that just didn't stop at the table, as I mentioned before. It didn't stop at the table. It doesn't stop at a meeting that you're attending within the open network, but that you're taking this and you're moving it back into the communities and sharing this in the communities in which are being served. So with that, for some reason, I can't go to the next slide. And so with that, we look to integrate with a purpose. And so as we moved into this independent network of Open Inc., and our structure began to even be formalized more. So we left DentaQuest, or not really left DentaQuest, but Open Inc. became the backbone now for Oral Health 2020, or now our open network. Health equity remains to be the center of our messaging and work within the network. So it was decided to further our work that was done prior in the health equity work group, but that it would look a little bit different. We would then think about, well, we decided to create what we're calling our health equity super network response team. And we're going to utilize our network response teams for the big push. And these teams function as action or learning communities around topics of interest to open and the oral health community as a whole. And so with that, this group comes together and our focus will be education, integration, and accountability. I say will be because we are in the beginning stages of developing our network response team around health equity. Even though we've been doing the health equity work, we have the toolbox already established to continue the work towards more education, integration, and accountability. We are devising this new group. We're also going to be looking more at internal versus external. So making sure that we're still empowering people at the individual level, but that we're also making the touch points externally as well. And that the staff is involved in that the staff is involved in their own growth and individual experiences and the formal leadership of the open network. Personal organizations as well, I kind of mentioned that, and our open discussions, meaning, no pun intended, we want to continue to have open discussions around equity, those things that make us uncomfortable, and continue to gain an understanding. We've been very intentional in our purpose here by forming this health equity network response team, or NRT. We want to make sure that we're able to integrate the ideas and issues from all across the network. And so we started this, I'm going to go to the next slide. So we started this, this whole idea with the thought that we would engage our formal leaders first to get that initial buy-in to ensure there's a level of accountability built into the process of development. Because we can talk about equity all day. We can use these words as just words and they sound good and they're good sound bites, but how do we hold each other accountable? We have to hold each other accountable at the leadership level so that we make sure that we have it into the entire process itself. And so under this umbrella group of this super NRT, not just the formal leaders of the open network, but we're also looking at our just members, everyday folk can come to the table and share their experiences and how to move these initiatives that we'll be developing forward. So collectively, we want to make sure that we're addressing all ideas of the members that we can. We want to make sure that we're functioning from a bottom-up perspective and not a top-down perspective, which a lot of times we know that's how policies are set. A little bit more here, and I have to move some things around on my screen. A little bit more. So our purpose and overall role that we've come up with our team, which included a team of everyone. It wasn't just Christy. I am one of the co-facilitators of the work group, but it wasn't just me. It wasn't just Stacey. It wasn't just other staff, but it really has been encompassing of the network itself. And so we want to maintain a focus on our network-wide value add to ideas of progress and equity. We will continue to confront systemic inequities and racism and how we operate as a network in oral health policy and the profession, developing strategies to impact these policy systems and move them forward. And we'll always be thinking through our ongoing learning journey because it doesn't stop. We'll continue to look at how we provide insight and accountability, and we'll talk about our equity checklist next, our bidirectional sharing and learning. And we'll be providing education, guidance, leadership, and connections to help implement equity tools by the staff of the network and our member organizations. So it's not just on the leadership, but this is a complete, entirely integrated approach to thinking of and thinking through equity. Alone, we can do so little. Together, we can do so much. We look to continue to ensure that as a network, we integrate these equity messaging and frameworks look at what we really want to impact broadly. Integration by the staff, the work groups, and the open teams, plus really looking at activities for members, and integration approach and response to our big picture policy and media, and applying and driving the use of our equity tools. So we really want to do this collectively together. It won't be just led by the staff. Once again, this is an initiative. Our health equity super NRT will be led by our groups collectively. So we continue to lean into the discomfort. Stacey mentioned that we continue to have conversations. We continue to figure things out as we go along, but we understand that the changes that we're looking for comes from discomfort and challenging ourselves. We want to be immersed in these discomforts and just challenge ourselves to change so that we can move into action. And with that action, we really think about accountability. How do we hold ourselves accountable? Accountability is one of the key focuses of our health equity NRT. And so we've been looking for ways to measure that accountability. And so we've come up with a couple of tools that I like to share because I think it's important to have some takeaways. I know Annalise provided some takeaways. We're going to provide a couple more because the one she provided was absolutely amazing. And so our equity checklist was created, and it's a combination of some tools that I'm going to share. So our ideal is we're looking for tools for change and accountability, being conscious of the diverse needs of the network beyond that racial lens, but looking at the invisible disabilities, rural areas, the different populations that we serve. This checklist with our equity checklist, we look to enact it as a practice to ensure that the disenfranchised communities are included and have an impact in the work that we do. This includes marginalized communities in a way that shares the power, reduces disparities, and leads to more equitable outcomes. We have begun to take this checklist into account when we are creating our agendas within the network, facilitating our meetings, having conversations. It's a way to ensure that we are doing what we set out to do. And so part of that is the SMARTY goals, the Hamas Principles, and we've created an equities survey evaluation. So we've all heard of SMART goals: smart, measurable, attainable, realistic, and timely. We've used them to create our strategic plans and our goals. But another part of that is the I and the E, which is inclusive for the I, which stands for bringing the traditionally marginalized people and communities, particularly those most impacted, into the process, into the activities, into the decision-making, and sharing that power as a whole. Making sure that when we're making decisions and we're setting goals strategically, that we're thinking and overlaying this into the work that we do. The E is for equitable. Includes an element of fairness or justice that seeks to address systemic injustice, inequity, or oppression. So that's the SMARTY goals. It allows us to just have meetings that are well organized, focused, and realistic, provides us with the tools to set goals that are ambitious, realistic, and have a clear completion timeline. Provides us with a framework that is inclusive of, as I mentioned, those marginalized people and communities, and addresses the issues on a systemic level. The other tool that we have begun to talk about and really learn more about is our health equity checklist. It is our Hamas Principles. We've incorporated this as another part of the checklist. The Hamas Principles have intentions on how we enter spaces. It changes that paradigm of doing work from that structural or internal, from that structural perspective to more of an internal, that spiritual piece, working together in solidarity and mutuality versus in those silos that we tend to see ourselves. Thinking of those untraditional partners that you can actually bring to the table and have conversations around this oral health and equity work. Building inclusion from the bottom up, as I've mentioned before, allowing everyone to have their own voice in the articulation and solution of the issues that they're facing, that we're all facing. Moving the work away from charity towards solidarity and connecting issues that affect us all as a community fighting collectively together. The Hamas Principles really focus on cultivating real relationships and a commitment. So moving away from those transactional experiences where we just want to get out here, we want to get numbers, we want to make it happen, to transformational, making sure there's quality in the work that we're doing, quality in the relationships that we're building between one another, creating positive reinforcements between one another, meeting people where they are. The last tool that I don't have a copy of is we actually have a survey to make sure that when we're setting meetings and agendas that we're taking into account the needs of those participants that will be there. So this survey asks questions, do you have special needs? Do we need closed captioning? Is it language translation? So we're trying to be inclusive of the experience for all and not make assumptions that everyone is in the same place, because we know on multiple levels when we talk about this, everyone is not on the same level. So that's another tool that we have begun to use. As you can tell, we're still learning. We're still figuring it out. We're still developing who we are and what we do and how we'll move through these processes for open. And it is a continued journey, a journey that I'm happy to be on and part of open as a whole. So we are excited. Once again, thank you. We are excited to have presented this information. And just to know that for us, the true measure of our success will be the number of people touched and transformed by our success. Transformation is going to come with all of us working together. And I think we are trying our best to get there. And I'm going to turn it back over to Stacey in our next polling question.
Thank you. Melissa, do we have time to do this polling question, or should we wrap it up?
We do need to wrap up. Thank you for asking. If you wanted to make this your last screen, that way we can start our next presentation. Thank you so much, Kristie and Stacey.
So what I'm going to say is, why don't you take us ahead to the last slide? Freeze. Right there. Okay, so I'm going to encourage folks, if you'd like to get involved in Open, this screen shows our online community, which is called Open Communities. I just posted in the chat a link. If folks want to go there, you can request an account there. There's no cost to join. Everyone is welcome. We'd love to have you take part. And please reach out to either Kristie or me if you have any questions about getting involved or any questions about our work. And our contact information, I believe, is in the materials that you have. Thank you very much, everyone.